Good morning, everyone. Welcome to NRBP's Eye Opener and today's discussion topic, Meeting the Challenges in Healthcare. Through the Eye Opener series, NRBP offers perspectives and insights from the Newark region's leaders and leading companies. We're grateful to our series sponsor, RWJ-Barnabas Health, and you will hear from them shortly. We also appreciate the support of an event sponsor, Quest Diagnostics, and our media sponsor, NJ Advanced Media. One of the highlights of every eye opener is the update from RWJ-Barnabas Health and Newark Beth Israel Medical Center. Joining us today is Linda Kamate, Senior Director of Public Relations and Marketing, representing the hospital's CEO, Darryl Terry, who could not join us today. Before Linda begins, I wanted to give a little bit of background on today's topic. We chose the topic because just about every day that we open the paper, we're reading about various challenges that the healthcare industry is facing. And we all are encountering those challenges, whether we're employees of hospitals, part of the system, whether we're patients ourselves, whether our children are patients. Everyone is impacted by what's happening in the healthcare system and businesses as well. So we thought it would be important to talk about various aspects while there continues to be continued attention on COVID, RSV, flu, and the concomitants of all of those things together. We invited speakers from different aspects of healthcare to share their perspectives, and I think you'll be pleased with the diversity of thought here. And as is true of all of our NRBP programs, thanks to the leadership of Maya Curry, our Vice President of Communications and DEI, every program that we feature includes a DEI lens. And we are always thinking about the disparities and social determinants of health when we have these conversations. So with that, I will invite Linda Kamate to begin the program and introduce our first speaker. Linda?
Thank you, Barbara. Good morning, everyone. You know, I'm looking at this screen this morning and some of your comments that you just made as well, Barbara. They remind me a lot of our safety huddle that we have at Newark Beth Israel every morning. Every morning at 8:30 a.m., we have all of our senior leaders, our vice presidents, directors. We all get together on a Zoom call, much like this one, and we talk about the safety concerns that we're facing at the hospital, some of the immediate issues that need to be handled. And there's such amazing diversity on that call, in that meeting. Diversity of thought, diversity of backgrounds, gender, race, you name it. But we're all gathered together under one mission. That is to serve our patients and to serve our community. When I look at that screen, and I look at all the people that are on those Zoom calls every morning, I think to myself, these are the people that got us through the pandemic. The staff, the employees that got us through the last 2 years. People like Amy Doran, who just became Newark Beth Israel Medical Center's first female chief operating officer. Amy's been working at the hospital for more than 30 years. She started as a student nurse in our emergency department in 1989. And then we have people like Atiya Jahar Rashidi. She grew up in this community and she dreamed of working alongside her grandmother as a nurse here at Newark Beth Israel. That was her dream growing up. And she did actually make it come true. She worked here, she stayed here. And today she is the first Chief Equity Officer at Newark Beth Israel Medical Center. We have a head of physical therapy, our head of the physical therapy department, who's always running back and forth from one meeting to the next, but he still has time to stop and help someone in need. And actually the other day, he just won one of our Good Catch Safety Awards for helping an elderly woman who was in the hallway and needed her walker adjusted. And he stopped and he helped her to adjust the height on her walker. And of course, we can't forget the man who came in every single day, every night to check on his team. He happened to be born at the Beth as well. And he happened to grow up to become our president and CEO, Mr. Darrell Terry. These are just a handful of people that I'm mentioning to you, but they are the people who are building this hospital and who make this hospital what it is today. They're the reason that we've earned 4 consecutive World Best Hospital designations from Newsweek. The reason we now have 5 HEI designations for delivering inclusive care to the LGBTQ community. And they're also the reason why today I can say that we've just earned Money Magazine and Leapfrog's Best Maternity Hospital in the US. These are our people. And them and so many others just like them are building our future. We just opened a state-of-the-art geriatric unit at Newark Beth Israel. By next spring, our ED expansion will be complete. Our 17,000 square foot glass enclosed lobby will be open. And soon after that, we'll be opening up our new ICU and new operating rooms. But what is it that makes all of these structures matter so much to us? Why do our people come in and come to work for us every day? I know today our topic is the crisis in healthcare, and a lot of it has to do with the Great Resignation. I know we've all felt it. But for us in healthcare, we know that we bring so much more to our profession. At the end of our safety huddle every morning, we read a message of gratitude, a grateful moment message. And I picked one that really stood out because I thought it speaks to everything that we bring to our profession, the passion and the personal commitment that we have. One woman wrote, "I am so grateful to be working in the Valerie Fund." That's our pediatric cancer center. She's been working there for the past 10 years in the same place where she was once a patient as a child. That's what this is. There's so much more to our jobs as healthcare professionals. We bring so much passion to what we do. And so I'm honored today to also introduce one of my colleagues. I'm honored to learn from him as a member of our senior management team, Dr. Josh Rosenblatt. He's the chair of pediatrics. He's been with Newark Beth Israel for nearly 40 years, leading the Children's Hospital of New Jersey and caring for some of the sickest children in our state. He's also leading the team that's managing this influx of children who are coming in with respiratory viruses, and he's going to talk to us about that today. Thank you, Dr. Rosenblatt.
Thank you, Linda, for those kind words and your apt description of what it is like to work at the Children's Hospital of New Jersey at Newark Beth. For those who are unaware, in about mid-September, we started seeing an unusually high number of children becoming hospitalized with viruses that are called rhino-entero viruses. And these infections, these viruses were causing children, especially children with asthma, to become very sick very suddenly. This surge of rhino-entero virus thankfully peaked in a short time and declined almost as quickly as it started. Unfortunately, this was followed almost immediately by a second surge, an unusually early and severe outbreak with another common virus called the respiratory syncytial virus, or RSV. RSV causes inflammation in the bronchioles, which are the smallest breathing tubes, and may lead to difficulty breathing, most severely in infants. And not long after the early start to this RSV season, we also started seeing influenza. And in the past 2 to 3 weeks, infections with influenza have steadily increased. Now, in addition to RSV and flu, we still have a small, steady stream of children getting sick with COVID-19. And as Linda referred to, a health system that is still reeling from the effects of the pandemic. Now, the reason that we are seeing this unusually large and high number of infections with common viruses is not completely clear. But one possible explanation is being referred to as immunity debt. And this theory suggests that the interventions that were used to decrease infection with COVID-19 also dramatically decreased infections with the other viruses, leaving a child's immune system unprepared and that child vulnerable to infection as the measures stopped. And while the exact reason for this increase is not completely clear, the effect is that together these infections have overwhelmed the portion of the health system dedicated to children. Currently, throughout the area, the city, the state, and even the country, pediatric emergency rooms are seeing 2 and 3 times the normal volume of children. And most acutely, pediatric intensive care units are likewise well above capacity, often exceeding physical bed space and usual nurse staffing. And there were times, excuse me, I must have muted for a second, where every PICU bed in the state, and PICU is pediatric intensive care bed, was full. And the thing that keeps me up most at night is the idea of what some people are calling the triple-demic, meaning simultaneous further increases in COVID-19, RSV, and influenza. Now, while the numbers in children are so much smaller than the numbers of adults hospitalized in March 2020, our baseline capacity for caring for these children is also much smaller. And for those who are not familiar with healthcare economics, hospital care for children is complicated, it is expensive to provide, and it is not adequately reimbursed. And this has led over the years to many hospitals either completely closing inpatient pediatric units or maintaining very small units, which causes hospitals like Children's Hospital of New Jersey to shoulder the burden disproportionately. And in normal times, we're more than able to meet that demand and happy to do so. But in these extraordinary times, it becomes very, very difficult. And what we're doing at the Children's Hospital of New Jersey, at Newark Beth, and throughout RWJ Barnabas Health is working very hard to expand capacity, both opening new physical spaces for children and utilizing novel staffing models to provide nursing care for the sickest children. We're also working very, very hard at coordinating care across the health system. We have daily meetings, not unlike the safety huddle that Linda described, with leadership across the health system so that we can ensure that children get care at the closest facility that has capacity in the moment. We're also working to expand telehealth to bring pediatric expertise to non-pediatric hospitals and emergency departments. But it is a struggle. We have children in emergency departments waiting for admission and in places that are not ideal. So what we're seeing is somewhat the end result of a healthcare system ill-prepared for even these modest increase in volumes. And so what we have to do is both simultaneously work to increase that capacity, as I just said, but also to prevent children from getting sick in the first place. And there are 5 things that I'd like you to think about as leaders in your communities and in business. And the first is to urge anyone who will listen to vaccinate themselves and vaccinate their children against flu and COVID. I would recommend that people stop temporarily bringing infants to crowded indoor places where we know the transmission of respiratory viruses occur. I would also suggest that when we as adults go to these crowded indoor places, we make the choice to once again wear our masks and prevent the transmission of these viruses. Two last things, again, that we learned or relearned during COVID. One is the importance of hand hygiene, and the second, the importance of staying home when you're sick and not sending your children to school when they are sick. And I think if we do these things, coupled with the dedication of the pediatric healthcare team, we'll get through what is another, in quotes, unprecedented crisis. Thank you for your attention. I'm afraid I will have to get off, but I will make the effort to answer any questions electronically.
Thank you so much, Dr. Rosenblatt. And also to Linda Kamate, because she really did share a lot about Newark Beth Israel Medical Center. We will, if there are questions for Dr. Rosenblatt, we will send them to him after the program, and we'll include that in our post event email. So we will get your questions answered. Thank you again. We now move to, thank you. We'll now move to our next speaker. Iman Gibson is Chief Clinical Officer for Integrity, and she will, I hope anyway, she'll say a word about integrity as she begins her remarks, because Integrity does just incredible work in many communities, including in Newark. Iman, thank you.
Sorry, I forgot to take myself off mute. Good morning, everyone. I will share my slides and share a little bit about Integrity. All right, so again, good morning. My name is Iman Gibson. I'm the Chief Clinical Officer here at Integrity House. Many of you may be familiar with us. We are based out of Newark for the last 54 years, and very privileged to just serve all 21 counties throughout the state of New Jersey as a leading provider for both substance use and mental health treatment. I joined Integrity House 10 years ago as a mental health clinician. And a little background about me: I'm a licensed clinical social worker and a licensed clinical alcohol and drug counselor. I have a specialty in working with individuals who are trauma survivors and transgender or gender nonconforming individuals. I want to talk to you a little bit about, the long-term impact on mental health following the pandemic, and also the increased access to fentanyl that we are seeing. There is so much research available today that speaks to, the increase in mental health challenges among our population, especially those with substance use disorders. But here I'm sharing with you a study that was conducted collaboratively between the National Institute of Health and the National Institute of Drug Abuse, where research reviewed EMR records for over 7 million clients. And at the time of the research, 12,000 had an active diagnosis of COVID-19. Their analysis concluded that the individuals who also have a substance use disorder were at a higher risk of getting COVID-19, and even a greater risk if they had a diagnosis of opioid use disorder specifically. Unfortunately, as we see with many cases in the healthcare industry, there were also disparities. Individuals who were African Americans had a higher risk of contracting COVID-19, with also adverse outcomes related to it. On the provider end, our observations are a little concerning. Right? We know that mental health is increasing. Mental health symptoms, challenges, complications are continuously increasing. Substance use is increasing. We are seeing an increase in overdose-related deaths, but we're seeing a decline in intakes in many cases. And there are many reasons for that decline, including just client perceptions, their fears, related to a change in workflow, having to go through additional screening in some cases. We're also seeing clients come in for reasons that may not be what our specialty is. For example, someone may seek treatment because they are simply seeking a safe place to sleep, and they may not be ready to engage in treatment. So working with that client will require additional work rather than someone who comes to us with the intent of receiving substance use or mental health treatment. We're also seeing a higher turnover in clients because of the rules that are in place as a result of the pandemic, including masks, restrictions on visits, originally vaccination in some cases. In the very beginning in 2020, for our residential programs, we weren't allowed to have family visits because we needed to just maintain the family that we had here. And for many clients, it's important, as it is for all of us, to see your family, and not having that access really did contribute to people leaving treatment prematurely. As is the case, I'm sure, with nearly everyone on this call, the burnout that our staff experience, just being on the front lines, managing their personal lives, managing the increase in demand with symptom monitoring, and just managing people's mental health challenges and working additional hours in many cases because of the staffing challenges. We also see our staff and the burnout that they experienced as a result of the pandemic. There are many studies as well to understand the emotional strain of COVID-19. And here, the Kaiser Family Foundation conducted a study in 2020 where they found that adults experiencing anxiety and depression actually quadrupled from the previous year. That's a very stark difference. And for those with mental health and substance use challenges, isolation wasn't optimal, but that was the preferred prevention strategy during the pandemic. Certainly, we recognize the need for it, but as the pandemic took its course, we in the mental health and substance use treatment field, we didn't really have an immediate opportunity to understand the long-term impact this will have on our clients who are already experiencing challenges, and what those who have not yet presented with symptoms, what this may look like for them. And it also took time to figure out, other strategies to put in place, telehealth, getting resources up and going, even providing masks or things like that that people needed that were not accessible. All that took time. Nonetheless, they had an impact during that time. And unfortunately, 3 years later, these numbers are not decreasing. Johns Hopkins University is currently finding cognitive dysfunction, psychiatric distress, and functional decline in those who have survived COVID-19 months after their infection. We talk a lot about the mental health, and mental health is very broad. So we've talked about depression and anxiety, the common symptoms that one may see, but it's well beyond that. And no research is really going to cover 100% of the things that may impact our different life areas. In addition to those mental health challenges such as anxiety and depression, we've also seen an increase in domestic violence calls during the pandemic. And not only does the domestic violence call suggest a dysfunction in the family, this is also suggestive of trauma experienced in the family, as well as adverse childhood experiences that children in the home may experience, which will have intergenerational impact on those children. An increase in crisis hotline usage. I did not include New Jersey numbers, but I thought the LA numbers were pretty stark, an 8,000% increase in the crisis hotline for suicide prevention. And also, of course, the continued decrease in staffing. While the needs for the population are increasing, the staff is decreasing for many different reasons, including, as I mentioned earlier, burnout. We lose clinicians to other fields where they may feel the work is not as challenging, or there may not be as much vicarious trauma. We lose staff to their personal needs, having to care for a loved one or family member who's sick. We may lose people who work on the front lines in hospitals and residential settings or in outpatient clinics to a telehealth setting, because it doesn't come with the same challenges, but it doesn't take away that the needs of our population is increasing while the pool of clinicians is decreasing. I think all of us would hope that these matters would subside, the pandemic would become more managed, and things would begin to stabilize. But we know through history that that's not what we can really expect. We know that anytime we have experienced such a pandemic, there are long-term effects. And there is research happening to understand those intergenerational effects right now, tied to specifically COVID-19 and mental health problems throughout the years. I want to talk a little bit just on the impact on substance use specifically for clients who are, or individuals who are experiencing substance use disorder. Isolation is possibly one of the worst things that we could ask of them or that they could engage in. And for many of these individuals, they were engaged in some form of a community support that could have been attending outpatient treatment, where they had a community, that could be attending a mutual aid group where they had a community. It could just be being around other people, even if they were actively using, but the difference is they wouldn't be using alone. When the pandemic happened, it was isolation only. Mutual aid groups immediately stopped and shortly after converted to virtual. Treatment stopped, outpatient treatment stopped, it converted to virtual, but there was that human contact that was very essential was now missing. And that resulted in, unfortunately, an increase in use, many more deaths, using alone, which resulted in many more deaths. And here we are today. In addition to just the isolation, there's the impact that both our media, specifically social media, had on substance use, either with those who were already diagnosed or those who developed new substance use disorders throughout the pandemic. Primarily tied to the acceptability of substance use, drinking. I saw so much things on social media. You're working from home while having a glass of wine, or you're bored, so you have a glass of wine, whatever it may be. But for some individuals, that may be okay. But for those who are suffering from a substance use disorder, that's not okay, and it could have a drastic impact on their recovery, and it did. In Jersey alone, 3,000 people died in 2021, and we're already on set to exceed that number with having over 2,100 deaths through the end of September. So we'll likely increase that unfortunate number of 3,000 for 2022. As we're seeing both mental health symptoms and as well as relapse increase, there's also the prevalence and the increased access to fentanyl, which is a synthetic opioid, not the same as the pharmaceutical fentanyl, 50 times stronger than heroin and 100 times stronger than morphine. Originally, we saw fentanyl, just heroin being laced with fentanyl, but today it's not the same. It's any drug essentially could be laced with fentanyl. We're seeing prescription pills being laced with it, marijuana, cocaine, anything is now being laced, and a small grain of fentanyl is enough to just take a life. It's not the same as the quantity for the other drug. The National Association for Boards of Pharmacy also found in a study 5 years ago, so I imagine the numbers are higher today, that 95% of those who were members were practicing outside of compliance, with 10,000 of them not requiring a valid prescription to get a controlled substance, and over 5,000 of those providers offering non-FDA approved medications, which could be a synthetic. So the access to it is not difficult at all. The DEA, of course, is continuing its efforts to, hunt down these sorts of activities and eliminate it. Of the 390 cases of fentanyl distribution reviewed by the DEA, in 2020, 129 were linked to social media, because that's how you can, who do you know that knows who, and it's also a great target. So to go back earlier to this slide where there's an increase in social media use, promoting the acceptability of substance use, it's just a way to, market what you have, and it's another way to just lure people in, especially the younger population today. The DEA is continuing to advise regarding fake prescription pills that are easily accessible on social media. But it's really important that we are all mindful of these things, regardless of the field that we're in, the work we do, whether we see it in our family or not. It's important that just as a community, we understand that mental health and substance use and relapse looks different for everyone. We educate ourselves and we remain available to everyone. We continue to promote the increase of mental health providers in the field. We ensure that mental health and substance use disorder treatment is enforced in our laws, and there are resources available to address these issues. We bring treatment to the person. Treatment does not have to look the same for everyone. For someone, it could be entering inpatient or residential treatment. For others, it could be telehealth. For many others, it could be street work. Whatever is going to work, we have to be open to providing that form of treatment and recognizing that it looks different. Abstinence may not be for 100% of the people. For some people, it may be. For others, it may be harm reduction. For someone else, they may, we don't want to label anyone. We don't want to box anyone into any category. So avoid the use of stigma. If you're going to use stigmatizing language, no one's going to welcome, no one's going to come into that space for help. They're going to shy away from it. We have to normalize asking for help. If someone is reaching out, while all of us are very busy, we have to hear the message from the person and not just shut them off. And many times this could be a family member, a loved one, because we're not at work. So we're just saying, that's just that person. They always do this. They're attention seeking. Maybe they're not. That could be a really important time where you can really bring help to the person. Regardless of your work, I encourage everyone to become trained in Narcan and have a Narcan kit available in the event that you do see someone overdosing. You can really save a life. And most importantly, I encourage everyone to adopt harm reduction practices, such as having access to fentanyl test strips, so those individuals who are using are able to test their substances to ensure that there is no fentanyl present, which may cause a death, and other practices such as being okay that some people are using, but how do you reduce the harm? How do you promote, safe access? How do you encourage them to seek treatment? How do you involve family? How do you make additional resources and options available to them? And I think together we can, just be available to our loved ones and save them from death being available in our life. That is all I have.
Thank you so much, Iman. That was quite amazing to hear all of that and to recognize that this is another aspect of COVID, and added to that, the continuing issues that you faced already. There are tremendous challenges, but we really appreciated that you included that last slide, which had recommendations for what we can all do to help with the situation, especially if we know somebody that's struggling. So thank you so much, and thank you for all that Integrity does. We appreciate it. Okay, next up is Dr. Peter Fisher, who is Medical Director with Quest Diagnostics. And it's my pleasure to introduce Dr. Fisher.
Good morning, everyone. Thank you. Thanks to our sponsors and, of course, to the New York Regional Business Partnership for inviting me to participate today. Just a little about myself. I don't have an introduction slide. Sorry for that. I'm a pathologist by training and serve as medical director for the East region at Quest Diagnostics, which is one of 6 regions across the United States. We provide, or our region provides, lab diagnostic services to 7 states across the Eastern Seaboard, including New Jersey, New York, Pennsylvania, Maryland, Delaware, Virginia, West Virginia, and DC as well. And our primary core lab serving this East region is located in Clifton, New Jersey. In the few minutes that I have, I'll try to give you a sense of the challenges we faced in lab diagnostics due to the COVID pandemic and also other virus outbreaks over these past couple of years, how we've met these challenges, and how this is evolving the way we look at addressing these challenges for the future, in terms of responding quickly, effectively, and at huge scale if necessary, so that we can deliver diagnostic results to healthcare providers and patients. And this first slide, as Dr. Rosenblatt so emphatically stated, just a reminder that we are in the midst of a viral tridemic or tripledemic of influenza, RSV, and COVID. And here you can see these are the data I just pulled up on Sunday from the CDC website showing the increase, these are the weekly numbers, increase in influenza on the left and RSV on the right. And the next slide, the next slide shows what's happening with COVID. Influenza and RSV, influenza, the season, and it's not reflected in those numbers, but the season, there are 6 million infections so far this season, more than 50,000 hospitalizations and almost 3,000 deaths. And looking at COVID, you can see, again, this is the latest weekly data from the CDC, 305,000 cases is the weekly total last week, 2,600 deaths, 3,500 hospitalizations. So we're clearly still in the midst of a pandemic, and of course now magnified with a triple-demic. So why is lab diagnosis important? The diagnosis of viral disease can dictate, for certain viral infections anyway, appropriate antiviral treatments or monoclonal therapy for specific infections. Over the past few decades, there's been quite a revolution in diagnostic methodology for diagnosis of viral disease, moving from culture of the virus, which takes several days to get results, to now employing molecular testing and viral antigen detection, which can provide results in just a few minutes. So that's a huge change in how we can provide rapid diagnosis. The challenges in lab diagnostics that we've needed to address over these last 2 years have included: how do we cope with rapid increases in test volumes at unprecedented demand levels, while simultaneously figuring out how we provide timely and effective information on novel diseases, all while facing, along with everyone else, resource constraints, supply chain issues, a lack of workforce talent with appropriate skill sets, and managing patients' access to testing, including where and how patients get tested and how we then get these test samples transported back to the lab and the results back to patients and physicians. And in viral outbreaks, most of this is generally done without any precise advanced knowledge of demand factors, such as testing volume and duration of the outbreak. And these challenges range from the annual seasonal flu and RSV outbreaks to epidemics and pandemics, including both known and novel viruses, such as Ebola, COVID, and most recently, monkeypox. So the next slide, please. How do we manage to intermittent demand and workforce gaps? Clinical testing personnel, as I said, continue to decline in numbers across the country in lab medicine and in microbiology in particular. And in microbiology, really high-level scientific skills and training are needed. So being able to automate at scale is key. With automated processes, we can readily upscale and downscale to current real-time demand and provide 24/7 availability. And with minimal hands-on time, manual errors are limited and the number of skilled lab scientists needed is reduced. Also, a key value of automation in the diagnostics of viral infection is the ability to maintain high-quality results, with low false positives and negatives, and to achieve a fast turnaround time with minimal rejected specimens or requests for patient recollection. So automation provides speed, efficiency, accuracy, rapid turnaround time, and quality. And our Clifton lab in New Jersey has the largest automation line in the world with end-to-end automation, all the way from receiving and identifying the tests that have been ordered on individual specimens to pipetting off samples, and then automatically routing those specimens to any one of the appropriate 60 instruments online. These instruments can run hundreds of different tests with the capacity today of 100,000
Dr. Fisher, I apologize. Dr. Fisher, restart your screen share. The window it closed for some reason. I'm not sure.
I'm still on. Shall I stop the video and start?
Okay, sorry, give me one quick second.
Yeah, mine is still on.
Okay, you're back.
Okay, so where did you lose me?
Sorry, we were still on this. You were getting to the end of this slide.
Okay, so as I said, well, I'll go just to say again, our Clifton lab has the largest automation line in the world, and providing end-to-end automation all the way from receiving specimens, identifying which tests are required on individual specimens, sending it to the appropriate instruments, which we have 60 plus instruments on the line. And we can run hundreds of different tests with a capacity today of 100,000 requisitions each day. And a requisition may have, as you know, 4 or 5 or more samples on each of them. So almost 500,000 tests a day in our Clifton lab alone. So the next slide. In addition to that, we also have a state-of-the-art microbiology automation line, which includes artificial intelligence-based analysis. This identifies organisms automatically alongside our medical lab scientists. So as I said, all told, the Clifton lab is capable of producing around 500,000 individual test results each day and eliminating many hands-on steps in this process. In order to manage the increased demand for COVID testing, the particular instruments that were capable of performing tests for COVID were scaled up by a factor of 10 in a very short period of time. And we also deliberately employed multiple platform types to mitigate resource supply limitations for any individual instrument, which of course had been a real concern for many months into the pandemic and still remains a concern. Managing new test development for novel viruses is of course hugely important, and time is of the essence since we can't predict which new virus will cause a pandemic. Going back to COVID, Quest developed and launched its own lab-developed test for COVID-19 on March 9 of 2020, which was 2 days before the WHO declared the pandemic. And then we offered a high-throughput test just 2 weeks later. And test development didn't stop there. One month later, in April, Quest released an antibody test, and in May, we were granted an emergency use authorization, an EUA, for nasal swab self-collection kits. And then in July, Quest was the first commercial lab to be granted an EUA to perform specimen pooling. And that's an important process development that conserves reagents in short supply. So in just 4 months, Quest had developed a new test for COVID, launched a high throughput assay, offered a self-collecting option to patients, and implemented specimen pooling. We have a similar story for monkeypox virus, where the first US case was reported on May 18 of this year. Quest developed and launched its monkeypox assay in 7 weeks. And about 7 weeks later, the FDA granted the first monkeypox EUA in the United States to Quest's assay, a total development to approval time of 3.5 months, which is staggeringly fast. And this monkeypox assay was unique in being the only one available in the US that didn't require confirmatory testing by the CDC. And very importantly, this assay was designed from the get-go with a simplified and streamlined protocol that would be amenable to high volume testing should the need emerge. Thankfully, not the case to date. Of course, standalone viral testing, is available for flu or for COVID or for RSV, but in patients presenting with influenza-like illness, especially during seasonal outbreaks as we're seeing now, combination tests may be most informative and efficient. For example, Quest offers combination testing on a single patient sample to simultaneously test for RSV, influenza, and COVID. But we also offer a larger panel that includes the 12 most common respiratory viruses, and we even have an extended panel that includes 21 viral and bacterial respiratory pathogens, all able to be performed on a single patient sample. And both panels include testing for rhino-entero virus, which Dr. Rosenblatt had mentioned earlier today. Another thing that our experience with COVID has underscored is that we need to provide people with easy access to rapid lab testing and diagnosis. And the next slide, please. Thank you. The places where we can access healthcare and diagnostics has dramatically changed over these last few years. And I'm not going to go through this, but possibly the most important emerging access point is the home, through both telehealth and also the expansion of at-home self-collection and self-testing options. It goes without saying that access to testing with rapid results is especially important for managing the spread of viral disease and enabling rapid quarantine or isolation decisions. Tests requiring a visit to the doctor's waiting room aren't the best medicine for managing contagious viral infections. So the promotion and capability of telehealth visits, together with at-home self-collection and testing, are incredibly important, which is an area that Quest is continuing to advance. Beyond providing diagnostic results to patients and physicians, Quest's scale and national reach, if you can have the next slide, please. So Quest scale allows us to leverage huge amounts of data to gain real-time insights into disease outbreaks. You know, across the US, Quest touches about 30% of American adults each year and generates over 4 billion results. During COVID, and in collaboration with the CDC and other large labs, the data we provided helped monitor the presence of COVID infection through looking at the presence of antibodies in patients' specimens across the country. And early on, the seroprevalence data showed evidence of COVID infection at a rate that was 10-fold higher than the case numbers being reported to the CDC. So these data also were the first confirmation of asymptomatic spread from person to person. And another very significant practical consequence of underreporting infection rates is that manufacturers use these numbers to determine the volume of reagents they're going to produce. So underestimates of true infection directly lead to limited reagent inventory being manufactured. Finally, the next slide, please. I just want to take a couple of minutes to mention the impact on patient screening in this era of viral epidemics and pandemics. You know, as you're all probably aware, fewer people, including myself, have sought routine medical care less frequently over the last 2 years. As you can see from this slide, I mean, it's 90% of decreases in colonoscopies, 70% decrease in doctor visits, almost 70% decrease in testing for HbA1c, testing for diabetes. This experience has been replicated. This experience of reduced doctor visits and screening is also replicated in the diagnostic lab, where we've seen a decline in routine screening lab tests, ranging from these well-care visit screening tests to tests monitoring for diabetes management and thyroid function. And we've seen fewer colonic, prostate, and breast biopsies. As a result, people are now presenting with more advanced disease states, including diabetic disease and its associated complications, and presenting with later stage cancers, where screening can be extremely effective in identifying early disease. But of course, when the screening isn't happening, the chances of catching that disease in its early stages is reduced. I don't have the answers, but it's important for us to recognize these kinds of consequences in our thinking about the management of viral outbreaks, and for us to work on finding ways to mitigate the longer-term medical health and, as you've heard, behavioral health complications of isolation and quarantine. So in summary, in providing viral diagnostics at a pandemic scale, our learnings at Quest have included the importance of automation, accelerated innovation, a careful consideration of patient access, and using real-time population data to guide clinical and public health decisions, along with a cautionary note to pay close attention to the longer-term consequences of any actions we take. Thanks for your attention. Thanks to Barbara, Chip, Maya, and the rest of the team for inviting me today. It's been a pleasure. Thank you.
Thank you, Dr. Fisher. And thank you also to Quest for being a supporter of this program. We work closely with Quest throughout the year. I'm finding it very interesting to hear the interplay between all of the different disciplines, and it's clear that you all play a role that's very, very interconnected. And I think that makes an excellent segue to our next speaker, Dr. Brian Strom, who is chairman of Rutgers Biomedical and Health Sciences and heads New Jersey Medical School. Brian, it's all yours.
Can you hear me now and see my slides now?
Yes, you're all set.
Yes.
Great, thank you. So thank you, everybody. And again, specifying in terms of background, I'm Chancellor of Biomedical and Health Sciences for Rutgers. In background, I'm a general internist, I'm a clinical pharmacologist, and I am an epidemiologist. So when it came to COVID, I happened to be the right person in the right place. And so But the topic for today is meeting challenges in healthcare. There were multiple different options that I talked about. As options, I could talk about population health, I could talk about financial, I could talk about manpower, I could talk about the current triple respiratory epidemic as we just heard about. All of these are impacted by COVID, and given the relative brevity of the time we have, what I'll do is I'll focus on COVID and the current state of COVID. Any questions on any of the others, I'm happy to talk about them in the Q&A box. In a new coronavirus with multiple genetic variants was discovered first in December 31st, 2019 in Wuhan, China, where there were 4 cases reported of a pneumonia-like disease. It was epidemic by February 2020 and declared pandemic in March 11th of 2020 by the World Health Organization. That's when the first cases as well in March of 2020 happened in New Jersey. Vaccination has proven to be the most effective strategy for prevention and control outside of public health interventions. And one of the things that has made COVID so striking is we had an overwhelmed public health system. Public health, unfortunately, is easy to cut when everything is going well. You don't have any advocates for the disease that you didn't get. And the public health system was quickly overwhelmed. To give you a sense of scale, the initial estimates, very conservative estimates of the number of contact tracers that would be needed in a state like New Jersey for a pandemic not nearly this bad would be 2,000. The total number of contact tracers available in the entire country at the beginning of this pandemic, the entire country, was 2,000. We ultimately trained up from the School of Public Health, trained up 2,000 for the state. So this was born, the public health system just couldn't handle this pandemic. And so a lot of the effort and weight fell onto the clinical system, which in turn was drowning. I can tell you we had, during that spring of 2020, I had every night calls with my leaders at 8 o'clock at night to try to deal with things. Look, you know, I'm happy to say that to my knowledge, no one in New Jersey died due to lack of a hospital bed. No one in New Jersey died due to lack of a ventilator, but it was touch and go, day after day after day. You know, at one point, one of my colleagues who is whose twin brother is on the board of Tesla. Tesla manufactured 50 extra ventilators for us. And we ended up needing to go, those ventilators didn't link right with the hospital hardware. So we went to our engineering lab to computer manufacture the needed links. It was that touch and go day after day. This is the current US COVID risk levels, and you'll see this color code throughout. Fortunately, most of the country is now yellow. New Jersey remains orange. There's only one state which is now red. This is based on case reporting, as we just heard about. I'll come back to the utility of that at this point in a minute. This is the average positive test rate for the US. So that positive test rate exceeds 8%. What that means, as a sense of ballpark, WHO gets nervous if it goes above 5%, because it means that of all positive tests, what proportion, of all tests done, what proportion are positive? Too many are positive. There are too many, that's an indication that there are a lot of positives being missed that aren't being tested or aren't being reported. This shows you the data on 7-day positivity, total and positive tests. This comes from the Hopkins system. Hopkins system has now stopped collecting testing data because it's just too incomplete. The data visualizations remain for past dates, not current dates, but there's no, they're not maintaining up-to-date information on test positivity and criteria because of how much underreporting there is. If you look here at case fatality rate of COVID, what made COVID different than the flu, we tolerate 20 to 50,000 deaths each year with the flu. We don't shut down the country for that. What made COVID different was for various characteristics which made it more contagious, more serious, and put people in the hospital much more commonly. So people were, the hospitals were overwhelmed, as I alluded to. And in addition, a case fatality rate, that is, of everybody gets the disease, what proportion die, compared to the flu that was 20 times higher than the case fatality rate of the flu. So this was, from the beginning, a dramatically worse disease, which resulted in the interventions that we're seeing. You look across different counties in New Jersey in November 21, this is what it looked like. Some counties ranged from yellow to red, with most counties orange. We were doing reasonably well at that point. Now, November 22, there are still counties in the red, but most are orange. And in fact, the state is doing well, though, as you saw in the prior data, not as well as some other places in the country. If you look at daily reported cases, you see the dramatic spikes. This is misleading early on, as the numbers looked low. They were low because it wasn't testing. Last winter, testing was available. As Omicron hit, you see this dramatic increase. And now it looks like it was solved. What's the problem? It looks like it's solved. The problem is, of course, that most testing is now being done at home, and these cases aren't being reported accordingly. So data for probably a year and a half, the data on hospitalizations have probably been more meaningful than the data on case counts. This shows you the data on hospitalizations. Again, you see the initial peak. You see peak last in 21, another peak last winter. Then it went down, which was reassuring, except this stubborn, persistent level that you see here, looking maybe like it is going back up here, but basically it's been level for a while. This is also misleading for different reasons, because these are people hospitalized who have COVID. And part of what has so dramatically changed during this pandemic is early on, people who were positive and hospitalized were hospitalized for COVID. Nowadays, the people who are hospitalized with COVID. That is, they're hospitalized for other things, and they're tested and found to have COVID. And so as of last winter, probably half of the cases of COVID were of that category. That is, they're hospitalized, they had COVID, but the hospitalizations were for other things. Now it's even higher than that in terms of the proportion that are incidental cases rather than people hospitalized for COVID. Are people still dying from COVID? As people in the ICU from COVID? Yes. Almost all of those are people who are unvaccinated. So the vaccination has dramatically changed. Percent vaccinated in New Jersey, we've done better than most states. 94% of New Jersey residents have received at least one dose. 78% are fully vaccinated with 2 or more doses. And the 40% have received an initial booster. Extremely few that have received severe reactions. Much lower rate, though, that have gotten the new booster, the combined booster, the bivalent booster that has just come out. Should people get a second booster? Factors to consider: timing of the first booster, the immunity varies over time, personal risk factors, what's your risk of being exposed? Are you a healthcare worker? Are you immunocompromised? What's your age? What's the risk of infection in the area? Part of why we're seeing the persistent increase, the persistent elevated number of cases in hospitals is there's a persistent elevated number of cases in the community. And that's simply a reflection of community risk. And have you recently contracted COVID? Because if so, it probably doesn't make sense to get another booster now because you have immunity from the recent episode of disease. The results of additional boosters may diminish over time. And so that argues that after enough time has passed from your prior booster or from getting the disease, it's probably time to get another booster. Variant evolution may evade vaccine immunity ultimately. And in fact, the newest variants that are out there at least seem to be evading immunity, at least based on test tube kind of data. Variant data in New York and New Jersey right now, 35% are BQ1 or BQ11, which are variants of Omicron that are not in the bivalent vaccine and seem to be seem to escape vaccination, at least if you test it against people who've had the disease, had the vaccination before testing for antibodies. BA.5 is now only 14%. As of August, it was 84%. And this shows you other variants as well. If you look across the world in terms of case numbers, and again, this given the limitations of case numbers, there are now well over 500 million people who have contracted this disease. These are confirmed cases. This doesn't count all the people who didn't get it confirmed. And this doesn't count the people who never got it reported. 100 million cases confirmed in the US, over a million US deaths from confirmed COVID. This disease has surpassed the number of deaths in most US wars put together. Remember, we went to war in Iraq with misinformation. We were the attack in New York had 3,000 deaths. This has over 1 million deaths that we know of. Cumulative cases in New Jersey, confirmed cases, now exceed 2 million. Confirmed New Jersey deaths, 30,000. Current New Jersey hospitalizations are right around 1,000, and that's been roughly stable for weeks and weeks, sometimes a little up, sometimes a little down. Currently on ventilators in New Jersey with COVID, 40, currently in ICUs, 135. Again, most of these are unvaccinated patients. And there aren't, if you look across the community, 95% of people now have immunity, either because of vaccination or because of having caught the disease, or both. Current statewide positivity rate is about 7.5%. So again, too high, indicating that we're missing a bunch of cases, because otherwise there would be more testing and a larger proportion of the lower proportion of those would be positive. Rate of transmission is 0.89. When you have a rate of transmission of 1, that means that each case is being replaced with another case. A rate of transmission above 1 means the pandemic is expanding. Rate of transmission below 1 means the pandemic is shrinking. These are New Jersey data, and it's been basically above and below 1 going back and forth now for a bunch of weeks. It's really been roughly stable. So what happens going forward? New Israeli data, again, we tolerate 20 to 50,000 US deaths each year from the flu. We shut down the economy when the hospitalization rates from COVID were much higher and overwhelmed our healthcare infrastructure, and given a case fatality rate that was 20 times that of the flu. The new data from Israel now in the Omicron and vaccine era, in people who take Paxlovid when they should, that is over age 65 or immunosuppressed, shows a 73% lower rate of hospitalization than people who didn't take Paxlovid, even in vaccinated people. There were only 2 deaths in 2,500 treated patients, a mortality rate of less than 0.1%. This is less than the death rate from flu in that age range. Those less than age 65 had milder disease, even without Paxlovid, but still benefited from Paxlovid. So between vaccines and Paxlovid, medical science has beaten this disease if the population would adhere to recommendations. These are striking data that the rate of death, hospitalization is so much lower, and the rate of death is so low, even in those over age 65, if they take Paxlovid when they should, and if they're vaccinated. So a little bit of epidemiology 101, epidemic to pandemic to endemic. An epidemic is when you have widespread occurrence of disease in a particular place and time. Examples are SARS, MERS, typhus, cholera, classic example. Pandemic is when an epidemic disease becomes prevalent across a wide region, continent, or worldwide. Examples are bubonic plague, the 1918 flu pandemic, which incidentally is still present as a pandemic, as a endemic, and COVID-19 Delta variant. Endemic is when a disease becomes regularly found in a population. Examples are malaria, influenza, HIV/AIDS, and I would argue COVID-19 Omicron. In the US, at least, worldwide, it's still pandemic. In the US, I think it has become endemic. It is something We have, it is relatively steady, and we will continue to live with, we will never get rid of it. Our opportunity, we had multiple opportunities to eliminate this disease. We lost them all. It's too late now. Once we passed Delta, the vaccine prevents hospitalization, it prevents death. It doesn't prevent, though again, we don't have the data on the newest bivalent, but short of that, it doesn't prevent infection, which means we can't prevent its spread by vaccinating. The purpose of vaccination now is to be sure you don't get hospitalized or die from it. Similar to flu. Living with COVID-19, our new world, multiple considerations. The reality is it is impossible to eradicate COVID-19 now. There will be an ongoing need to reduce personal and community risk. We need to look at the level of community risk, which now is and has been a steady lowish to moderate right now for weeks and weeks and weeks. It will go up in about 10 days in response to Thanksgiving. It'll go up 2 weeks more, 2 weeks after Christmas. But at least my own sense, I don't think we will ever be where we were a year ago, fortunately, with Omicron, unless there's a variant that emerges that is dramatically different. The natural history of viruses, they become more contagious and less virulent because they spread more effectively that way. If you kill your host, you can't spread. And if you, that's what's happening. And even the newest variants, which seem to be evading immunity, don't seem more severe. So we need to accept the reality of a new level of risk in our lives forever. And this will vary depending on the circumstances of individual people's lives. It'll also vary based on vaccination status of children. Very few children have been vaccinated, and so they're not protected. We need to consider that when we think about these things. Control measures, vaccinations, use of well-fitting masks, and testing for the virus at home. Impacted activities are indoor dining, air travel, socializing with elderly people or people at high risk, attending movies, theater, concert indoors, visiting other persons at their homes. All these are things you need to think about as you make your decisions for yourself. Do you have somebody at home who's at higher risk? Are you about to see a family member who's immunosuppressed or at highest risk? Have you recently been exposed in terms of air travel, for example, or indoor dining? When you go to theaters or concerts, wear masks. And are the people around you wearing masks? These are all now individual decisions you need to make. And how you make those decisions will be more individualized. More individual tailoring rather than earlier in the pandemic. Risk-benefit decisions will no longer be one-size-fits-all decisions in terms of lockdown, school closures, and restrictions on mass events. Everybody needs to be aware enough of all this so they can make the decisions for themselves, which varies by people, it varies by situation, and it varies over time. If you're going to go visit family members who are at high risk, you may not want to take a trip in the 2-3 weeks before that. If you're not, then you can feel more comfortable taking a trip 2 or 3 weeks before that. How do pandemics end? There's no clear-cut endpoints. It's more a social decision than a biologic decision. When we could have beaten this back, it was a biological decision. Now, at this point, it's a social decision. We will live with this for the rest of time. And it's a matter of what risks are we willing to take. Basically, it's over when we say it's over. It will never, as a pandemic, it will never disappear. It will be and is endemic. So almost lastly, will there be another pandemic? Yes. Climate change is impacting infectious disease spread. Ironically, when I went to public health school, which was at Berkeley in the late 1970s, epidemiology divides itself into 2 general categories: infectious disease and chronic disease epidemiology. I was literally taught that infectious disease epidemiology is a dead field because we know all the answers. That was at Berkeley in the late 1970s as HIV was cooking in San Francisco across the bay. Obviously, time has proven that very wrong. And we see with monkeypox and other pandemics coming, SARS more recently, there will be other pandemics and the pace of them will increase because of development and climate change. Animal vector habitat loss increases the likelihood of spillover into humans. We have public health amnesia, meaning we start cutting public health infrastructure as soon as the pandemic is over. Ironically, the one thing that the state did not renew in the Rutgers budget this year was our, at that point, newly formed Center for Pandemic, for COVID and other pandemic diseases. That wasn't renewed. What will the next pandemic be? Certainly long COVID variants, other coronaviruses are going to cause issues. Influenza, of course, always. Monkeypox, hemorrhagic fevers. We currently have an Ebola travel advisory in effect for Uganda, Zika, encephalitis, and who knows what else will course over into people from animals. So again, thank you for your attention. This comes from the New Jersey Turnpike. That was thanking our healthcare workers from the bottom of our hearts. Left-hand side, Jersey Turnpike, the right-hand side, a vaccination site and vaccination and testing site that we opened early in the pandemic. This has been a rather exceptional 3 years, which I hope not to repeat. But we're very proud of the contributions we have been able to make at Rutgers to the addressing the pandemic at Rutgers, for the state, for the nation, and for the world. Thank you.
Excellent. Thank you so much, Dr. Strom. Just a whole lot of information. I have a bunch of questions myself, but in the interest of time, I am going to turn to our next speaker, Dr. Mitchell Vogel, who is Senior Medical Director at Horizon Blue Cross Blue Shield of New Jersey. Dr. Vogel. Muted. Yeah, still muted.
Dr. Fogel, I just sent you an unmute request. You may
There
see
we
a
go.
box.
Can you hear me now?
Yeah, excellent.
Okay, great.
Thank
Sorry
you.
about that. My apologies. So as a little bit of background, as others have done, I'm a nephrologist, a kidney doctor by training. I was in practice for over 20 years in Connecticut. I gradually transitioned to become chair of medicine, and then I was a hospital chief medical officer. And I've been with Horizon for the past 2 years, really following my interests in population health. And today I'm going to be talking about 3 topics. And excuse me just a second. Let me get the right talking points up here. First is going to be the pandemic and really focusing on the effects on behavioral health. The second is value-based care and what Horizon is doing. And finally, there were some questions that Barbara asked that I speak about Horizon's conversion to a nonprofit mutual holding system. So the COVID pandemic certainly has upended the entire healthcare system. Dr. Strong spoke at length about the effects on the physical health system. I certainly have my own horror stories from being in New York City at the time of the initial outbreak. And I'd like to really talk a little bit about what's gone on in the behavioral health system. At Horizon, we've certainly seen an increased need for behavioral health services from our members. And this has really ranged from adjustment reactions to serious mental illness to substance use disorders, which Emmon spoke about at some length. I believe the largest increase in behavioral health needs has been in younger members. And the pandemic really has created a need for us to identify new ways to treat and meet the behavioral health needs of our members. Also, as Amen pointed out, I believe social media has really played an outsized role, especially in younger people. And in many ways, it's exacerbated the behavioral health issues rather than help resolve them. COVID certainly created and forced social isolation among children and adolescents. And that's so important for normal development of young children. And social media really, rather than promoting integration in some ways, by presenting stories and presentations that weren't necessarily accurate, but really representations of an image or persona that somebody wanted to create really led a lot of young people to really compare themselves, not to reality, but to presentations. And in some ways that really worsened young people's functioning and the way that they were really dealing with the crisis. Telehealth has certainly played a very important role, not only in physical health, but in behavioral health as well. Especially in behavioral health, it's eliminated a lot of barriers to care. People no longer needed to travel to see a behavioral health provider. They could do it in the privacy of their own environment. They didn't have to be embarrassed about being seen to go see someone. In large, a lot of the stigma around receiving behavioral health services really has decreased in the setting of COVID. Recently, we have seen some increase in face-to-face encounters. However, we certainly expect that the remote telehealth services are going to remain a major, if not the dominant form of behavioral health delivery. Part of what Horizon is doing is looking to digital solutions and new modern ways of reaching people's needs. We offer a service called Able To, which is an ability to really receive services online and remotely. And we've seen a very significant uptake, and a lot of people are very satisfied at that. We continue to look at other digital solutions as they become available, with certainly some concern about needing to understand that there's so many startups out there in the marketplace, and we want to be certain that the digital solutions that we endorse are going to be those that have staying power, that have a real need, have a clearly identified plan for service, and we want to ensure that those services that we're offering are those that are really going to meet members' needs. Challenges in terms of behavioral health are quite significant. We expect approximately a 50% increase in the need for behavioral health services over the next 10 years. And part of the challenge at this time is the number of psychiatrists in practice is expected to decline, really due to aging and changing patterns of training of young physicians. We certainly have seen challenges getting psychiatrists into our network. In physical health, over the past 10, 15 years or longer, we've seen physical health providers really coalesce into large groups or combine with hospital systems, and largely that reflects the growing need for quality reporting, regulations, overhead, and a variety of other market forces. Psychiatry is a little bit different, much like plastic surgery. There's a real mismatch between supply and demand. Psychiatry also, there's a real need for privacy, which isn't necessarily the case. Psychiatrists tend to work more independently rather than in concert with other providers. And there's a high-end private market in psychiatry. So for all of these reasons, what we're seeing, and we're not alone in this, is along with our difficulty getting psychiatrists into network, is we're seeing more care being moved to non-physicians, advanced practice nurses, social workers, licensed counsels, family therapists, and we believe that landscape is going to continue to evolve. So at Horizon, in summary, we are seeing an increased need for behavioral health services. This is especially pronounced in children, where social media appears to be having an oversized role. Telehealth is here to stay, especially in behavioral health, and workforce challenges, just as our other speakers have talked about, continue to be very prominent. I want to talk for a minute about value-based care and what Horizon is doing to improve outcomes and help contain costs. Value-based care really can be defined, as some people say, by any form of healthcare payment that's different than individual fee-for-service. And fee-for-service is you go to the doctor, you have a service provided, and you get paid for it. And value-based care is really where that payment is tied to some sort of outcome. A very simple example might be a large group of doctors in one group that have treat 1,000 people with diabetes. Another large group treats another 1,000 people with diabetes. Well, if one of those groups is doing a better job in terms of getting their diabetes under control, less emergency room use, less people going on to dialysis, less people becoming blind, should they get paid the same as the group who doesn't have such good outcomes? And Horizon really has made a commitment to value-based care in the future. Horizon has approximately 30.6 million covered lives, and about half, or 1.8 million, are currently in value-based arrangements for primary care. And as you know, in New Jersey, we have something called the Omnia Network, which includes all of the large provider systems in the state. And basically, the premise is that these groups agree to a negotiated total medical expense for all of their attributed members, but they agree to try to keep the spending of their members under these agreed upon limits. Members are then attributed to a certain provider system according to that system, which provides most of their care. So of the 1.8 million, about 2/3 or 1.2 million are in shared savings programs. And that's when the provider system is able to keep total medical expenses lower than the negotiated total. They receive a portion of the savings. So that group of primary care doctors who are or endocrinologists who are treating people with diabetes, when they see improved outcomes and lower expenses, they then get a share of those savings. About 600,000 of those members are in two-sided or shared risk models. And in these models, the providers get a larger fraction of the shared savings when expenses are lower than the total medical expense budget. And unlike the first model, they agree to rebate a portion of the expenses that exceed that budget. So it's really moving along the risk continuum. So as groups agree to take on more risk, they get more of the benefit. Now, so far, we have a very small number, only about 20,000 people in full risk models, and that's primarily in our Braven, which is our Medicare Advantage product. And that's a joint venture between the large system and the Horizons, where the providers are really now co-owners, and they fully share in the profit and loss of that organization. In addition to our primary care models, we also have episodes of care model for specialty care. The first one that most people have experience with is maternity care for quite a long time. Obstetricians have been paid a lump sum for all the maternity care. So that concept of lump sum or bundled payments, or we call them episodes, is really now expanding into bariatrics, orthopedics, and even into some forms of oncology. The results of our value-based system really have been quite positive. We've seen that the increase in medical costs for those members who are attributed are approximately 1/3 that of traditional fee-for-service members. So we haven't been able to reduce costs, but we've certainly had a very noticeable ability to control the increase in costs. And that's done primarily by controlling the days in hospital and emergency room visits. And at the same time, we've actually maintained or improved quality metrics, such as diabetic control, cancer screening, and some measures of satisfaction as well. And the way that we've done that really is through 6 levers where Horizon really partners with our provider systems. The first is we share data on how members are doing. And interestingly, traditionally, doctors' offices don't know how their patient's doing. They know how Mr. Jones is doing, how Mr. Smith is doing. But if you ask somebody of your 1,000 diabetics, what are their outcomes? Your 1,000 people with COPD, how many end up in the hospital and whatnot? So we're starting to, and have been for a number of years now, sharing that data with the provider systems. Secondly, we provide resources to the partners so that they can develop that population health infrastructure. Again, traditionally, doctors haven't dealt with looking at the outcomes of their patients, and they have to learn and have the resources to understand that data and to be able to work on it. We recognize that behavioral health is an important part of member health. And in some ways, that division between behavioral health and physical health is somewhat artificial. And as anyone in primary care knows, there's a lot of behavioral health issues out in the community. We have something called our integrated systems of care for those people with serious mental illness and substance use disorders. And it really provides a caseworker that really helps coordinate their behavioral health needs with their physical health needs, because again, all too often those two occur in isolation. So we're actually working hard to reduce those differences and really to get everybody working in synergy with each other. Horizon recognizes that medication costs are the fastest growing portion of the healthcare dollar and healthcare costs. And we have programs underway to appropriately utilize the specialty medications, which then helps control costs. Gene therapy is rapidly expanding, and Horizon certainly has an eye on that. Certainly gene therapy has great promise, and we want to make it available to our members, but we want to be sure that we're making it available in an appropriate way, so it's being used really to improve health in the way that it's designed. And in addition, we have a recognition that social determinants have on health. It's been said that your zip code is a better predictor of your health outcomes than your genetics. So certainly there are so many social factors that are present. And this is not just in the Medicaid population, but certainly a lot of lower waged employees as well also have very significant social factors. We have a program called Neighbors in Health, which helps people really get in touch with community-based resources, whether it's food, transportation, childcare, or really whatever the challenge is that they're undergoing. And then finally, one of the other aspects that has allowed us to move forward is by transferring medical management functions to the providers. And these are things such as case management and utilization management. So the provider partners themselves are doing those services and providing those functions rather than Horizon. And that's really part of the overall goal of moving a progression along the risk continuum so that we get providers really to be partnering with payer systems to really accept risk and manage not only the medical part of people's care, but also manage the costs of their care as well. So in summary, Horizon is implementing value-based arrangements really to improve the outcomes of our members and to control costs. And we're doing that really by working with providers to steer to really evolve into a new healthcare model in New Jersey. And finally, I want to talk for a minute about Horizon as a nonprofit mutual holding company. That's something that's been in the press a bit. And basically what this does is changes the corporate structure of Horizon. Horizon remains a nonprofit. Horizon remains under control of the variety of state regulations, which are still needed. We continue to be committed to the health of our members and continue to be committed as a nonprofit to the benefit of our members in New Jersey. What's happened is the healthcare industry really has changed a lot in the past number of years. Some of you may know that United Healthcare has a subsidiary or branch called Optum, which provides a large number of healthcare services. Cigna offers Express Scripts or ESI. Aetna and CVS Caremark really are really tied at the hip. Humana has put a lot of resources into something called CenterWell, which is for home care. And it's not just the for-profits, but also the nonprofit Blues across the country have done made similar conversions as Horizon. We've seen it occur in Florida and Michigan, for example, and that allows them to then launch products and services and bring those to the marketplace. So basically, this new structure really allows Horizon to innovate and to provide subsidiaries that are providing new services and allow them to come to market. We've had our first service, which was very recently launched, called NovaWell. And this is a behavioral health integration service. So other plans across the country are also trying to integrate their behavioral health and physical health delivery systems. And NovaWell really builds upon Horizon's health in that regards, and is really intended to help other health plans and health systems move along that same sort of integration within their existing systems. So in summary, Horizon as a nonprofit mutual holding really hasn't changed much. It remained a nonprofit, remain needing to meet regulatory requirements within the state. What it really does is allow Horizon to offer some new innovative services out into the marketplace. So with that, I'm happy to return to Barbara.
Thank you so much, Dr. Fogel. We ended up covering so much that we don't have any questions in the Q&A. So I'm going to turn to Chip Halleck, President and CEO of NRBP, to close out the program.
Thanks very much, Barbara. And I won't take much time at all because we've had a very detailed and comprehensive look at the challenges of the healthcare system, both in the past as well as how those challenges will be met in the future. And I think one thing that we've listened to this morning is just the appreciation for the constant evolution and the response of our healthcare facilities, the people in healthcare, the laboratories, our educational system, insurers, how they've helped to get us through these past couple of years and how to do so again in the future as well. And I think just the underfunding of public health was underscored this morning. The responsibility of ourselves to keep our families, our children especially, as safe as possible during the triple threat of the various viruses. And I think we just need to be all to be smart and in order to be healthy in the days ahead. So thank you very, very much to our speakers. Thank you to the healthcare workers that strive every day to keep us safe. And thank you to RWJ Barnabas and Newark Beth Israel Medical Center for the sponsorship of the Eye Opener series throughout the year. Take care. Thank you very much.